Okay, folks, we're going to give everyone about another minute to get in the room, and then we're going to get started.
We're going to get.
Okay, everyone, it is 12 o'clock Eastern time. Other times around the US and the world, we've got people joining us from all over the world. So I'd like to welcome everyone to the 2023 IDF PI conference. My name is Chris Scout-Schuns, and I'll be your moderator for today's session, Autoimmune Conditions and PI. I'm excited to welcome Dr. Verbsky, who will be presenting this very important topic. There'll be time for questions at the end of the presentation. Please submit any questions you have to the presenter in the Q&A section of the CVent platform. Today's session is sponsored by Takeda. IDF is incredibly grateful for their ongoing support of our education and learning opportunities. James Verbsky, MD, PhD, is a pediatric rheumatologist and clinical immunologist at the Medical College of Wisconsin in Milwaukee. He trained at Washington University in St. Louis, where he received his MD and PhD in immunology, as well as training in pediatrics, pediatric rheumatology, and clinical immunology. He's been at the Medical College of Wisconsin since 2005, and he sees children with rheumatologic issues, as well as children and adults with immune defects. His research involves investigating patients with immune defects and rheumatological disorders to define the genetic causes of these diseases. Thank you very much for joining us today, Dr. Verbsky. I'm going to turn over presentations to you. I think you're on mute at the moment, Dr. Verbsky.
Okay.
We're good.
Okay. And can you see my slide?
Yes.
Okay. Thank you for that introduction and for the opportunity to talk to all of you about autoimmunity and primary immune deficiencies. I added a little bit. It's much more common than you think. I trained as a rheumatologist, but saw immune deficiency patients, which was a really nice training because we see so much autoimmunity and immune deficiencies as well. So I'm hoping to go over and try to explain why that might occur. Okay. So these are a couple of questions that were posed to me regarding relationships between primary immune deficiency and autoimmune conditions. Can autoimmune disease mimic a PI disease? More likely the other way around. PI disease can mimic autoimmunity. Do the treatments overlap? And does having one make you prone to have the other? All right. So autoimmunity is an interesting question. And a very confusing topic, but it's defined as a misdirected immune response towards oneself, one's own tissue, one's own proteins, any other type of antigen in the body. And I listed a whole bunch of different autoimmune diseases. Pretty much every organ has an autoimmune disease associated with it. Common ones are rheumatoid arthritis, systemic lupus erythematosus, multiple sclerosis, type 1 diabetes, etc. Blood autoimmunity like hemolytic anemia. You'll hear me say ITP a lot. That stands for immune thrombocytopenia. That's when we attack our platelets and you bleed, and a number of other ones. And the definition of autoimmunity is having autoantibodies. So you make antibodies to self, or you make T cell responses toward oneself, one's own organs and tissues. Again, as I'm sure everyone here knows, and as most of you are probably pretty up to date on immunology, B cells are important and they secrete antibodies, and T cells help B cells make antibodies and also secrete a lot of proteins called cytokines that will activate inflammation and immune responses. So it's T and B cells defects that give us autoimmunity. They're the ones that drive these diseases. You get autoimmunity when a concept called tolerance breaks down. So immune tolerance is a concept where our immune system can see pretty much anything out in the world that we might be exposed to, but doesn't attack us. That's how it's supposed to work. That's a very complicated mechanism, and I'll go into that a little bit, but ideally that's how you want it to work. So can you have autoimmunity and primary immune deficiency disorders? And I'm going to abbreviate those as PIDD, just so if you see that. And, it's a very naive question. Well, if your T and B cells aren't working like an immune deficiency, well, then how can you have autoimmunity? And that's oversimplified. So let's back up a little bit. So why do we have autoimmunity? And as I mentioned, our immune system has to be able to see every pathogen that might attack us that's out there, and including pathogens that are evolving. So, for example, HIV didn't exist until the middle of last century. And we all know that COVID, we did not have COVID before 3 years ago, but our immune system could still respond to it. And this is not a system where we evolve with pathogens, like they evolve and we evolve. They evolve too fast and mutate too fast. There's no way we could evolve that way. So our immune system does it a little different. And how do we do this amazing feat where we can see anything in the world at any time and anything new? And how we do that is the fact that our lymphocytes, our T and B lymphocytes, each cell has one receptor that sees one thing. But we have billions and billions of lymphocytes all seeing different things. And how do you make billions and billions of different specific receptors? They can't be single genes each time. Our whole body would be immune receptors, all of our DNA would be. Well, the way we do it is we have little pieces of DNA where these receptors are in our genome, and they all get randomly mixed together. And it's a very random process, and there's hundreds and hundreds of them, and then you combine them randomly to get billions and billions and billions of different types of receptors. Now, this process is random, which means some of the receptors are going to see self, some are not going to see self, so they're going to see something foreign, and some don't really see anything and don't work, and those just get destroyed. So what we do is we make every receptor possible, and then we turn off or kill the cells that see us, and that's how the process works, and that's called tolerance. And so, when you think about this process, it makes sense that we would all make these receptors against ourselves. So in a normal individual, a tolerant individual, we are tolerant to our self-antigens because the T cells and B cells that are made that see us either kill or they're inactivated. Those are the two ways they do it. And if this breaks down for any reason, you get autoimmunity. So how does this work? How does this actually work? Well, actually, it's actually not as complete as you think it is. So you think that we'd be able to kill all the T cells and B cells that see self. Well, actually, a lot get out into our tissues. We see them all the time, and our immune system sees self all the time. And I'll show you it's kind of a scary feat. So don't read. I don't know if people can see my pointer. I just kind of said this, but here's a video or a diagram of how these little pieces of DNA all randomly come together to make our T and B cell receptors. And if you look down here, when you look at the numbers of different receptors, I don't know what 10 to the 16th is, but it's a billion times a billion, I think. And that's for T cells and B cells. So you see it's enormous diversity. We have the ability to see millions and billions of different things out there. We can actually measure these things from your blood. We can actually take blood from a person and look and say, how many of your cells see HIV or how many see influenza? And that's down here. And this is showing for CD8 T cells. And this is the frequency in the blood. So you can see they're pretty rare. This would be 1 out of 100,000 is about here. So out of 100,000 lymphocytes in your blood, one will see HIV, one will see, this is influenza, hepatitis C, and CMV. These are all viruses that we see. Interestingly enough, these are self-antigens. GAD is an antigen we see in diabetes. It's the same frequency. So the point is that we have these cells floating around, and everyone has a possibility to get autoimmunity because these cells could take off and start attacking us. But that doesn't happen very often. And that's from tolerance. So why does this happen? This is a very, I don't want to get too much into this because this is getting in pretty basic B and T cell development, but basically this occurs at two places. In our thymus, remember T cells are called T cells because they're on the thymus, which sits on the heart, and B cells are made in our bone marrow. And when they're developing, they're very sensitive and they'll die very easily. And what happens is they develop, and if in the thymus, this receptor sees a self protein that's being expressed in the thymus, the cell will die. That's called apoptosis. And that's getting rid of a lot of the self-reactive T cells. The thymus has a ton of death. When you look at it, a lot of cells are dying. B cells can sometimes change their receptors. But another thing that happens, and I wanted to highlight this because we'll talk about diseases associated with this, is some of our T cells actually become what are called regulatory T cells. And these are incredibly important cells in the immune system in that they inhibit immune responses. So they see self, they see antigens that we all have, but then they go out and they turn off immune responses. So these are a couple mechanisms that happens when the cells are developing and being kind of developing into mature lymphocytes. But that's not the only issue, because I showed you that in the blood, we have mature lymphocytes that see us. So there's other mechanisms. And when you don't activate a lymphocyte in the correct way, it'll either get inactivated and do nothing. That's called anergy. It may die, or Tregs will shut it down. So all of this comes together to try to control these self-reactive T and B cells. Oops. I got to move my video is in my way. Okay. So this was my original naive view on immunity, and autoimmunity this is kind of how good your immune system is. And in the middle here, you're normal. If it's not working well, you have an immune deficiency, you get infections. And if it's working too well, if it's too active, then you can get autoimmunity. Well, that's a very naive view and not correct. This is probably a more correct view, is that autoimmunity and immune deficiency overlap quite a bit. And actually, we see more autoimmunity and immune deficiencies than we do in normal people who can get autoimmunity. So this is probably a more accurate assessment here. So why is that? Well, it's kind of ironic, right? I mean, it makes sense that if you have an immune deficiency disorder, you'll get infections. That makes sense. Doesn't make sense if your immune system isn't working, you can get autoimmunity. I'd say that's kind of nature's sense of irony. It's a very well-balanced system, and any perturbation can result in autoimmunity, or we call immune dysregulation. All right, so actually, because of genetic sequencing and the Human Genome Project and all the amazing technologies that we've learned quite a bit, is that there's not just immune deficiencies that give you infections. There's actually immune deficiencies that just give you inflammation or autoimmunity. So this is kind of what I'm showing here, is you want to be here in the middle. I'm breaking this down. I don't want you to get too bogged down in this, but there's defects of our what are called innate cells. Those are your neutrophils, monocytes, complement, those kind of things. And then there's defects in T and B cells. So if your T and B cells don't work, you have what's called an adaptive immune deficiency. So stuff like severe combined immunodeficiency, or B cell problems like common variable immunodeficiency, those kind of things. Well, there's actually defects where your T and B cells are just uncontrolled and unregulated, and they're very good at attacking us. And there's a couple disorders I'll talk about to show you that. So this is still an immune deficiency. The immune system isn't working correctly. It's just you get autoimmunity, not infections. And we see that we have hundreds and hundreds of immune deficiencies, and we try to break these down for us to understand. But let me explain a couple of these to you. All right, here's one that's an interesting one. It's called APECED. This is a pure autoimmune immune deficiency. This is used to be called chronic mucocutaneous candidiasis. Now, I'll talk about the candidiasis as thrush. That's a yeast that they get. I'll talk about that because that doesn't make sense. But these patients, if they have this disorder, very early on, they get autoimmune hypothyroidism, and they have calcium problems, and kids can have seizures. They have their adrenal glands get attacked, so that can be very life-threatening. Nowadays, we can treat that pretty simply. They get all kinds of stuff. They can attack the reproductive organs. Vitiligo is shown over here with attacks your skin and you lose your pigment. Pernicious anemia. There's all kinds of autoimmune responses. And what is this autoimmune disease or this disease? It's due to a gene called AIR. And simply put, this is a protein that drives expression of all of our proteins in our body in the thymus. And it does that so that as those lymphocytes are educated in the thymus, they can see self and be deleted. And if they're not deleted, then this is what you get. You get a lot of endocrine problems. In addition, you don't make those good T regulatory cells against. You don't delete cells. You don't make T regulatory cells. So this is a good example of what happens during development if your cells can't see all of your self protein, self antigens in your body. Now, why do they get yeast? This was a very interesting and controversial finding. Is it turns out that they make autoantibodies against a protein that our T cells make to help fight yeast. So it's an autoimmune response against our immune system, and then you get an infection. So it's not just a susceptibility to it. It is a susceptibility to fungal infections, but it's because of an autoimmune response. It's kind of interesting. So this is pretty much a pure autoimmune response. This is not like your immune system isn't working and you're getting lots of infections. So the system is much more complex. Here's another one. I told you about those T regulatory cells. So they're controlled by another protein's called FOXP3, and it's X-linked, which means it affects boys. Moms just carry it and they only give it to boys. In this case, they have no T regulatory cells. They can't make them. This is a incredibly serious and aggressive autoimmune disease. These boys can be born normal, but very early on, they get every autoimmune response you could imagine. They get type 1 diabetes at a very early age, inflammatory bowel disease, severe eczema. They get food allergies and can't eat. They get hemolytic anemia, pretty much anything you can imagine. As a matter of fact, they can attack themselves in utero. So inside mom, when they're not born yet, they can even attack themselves. So this is a very aggressive autoimmune response. And you basically have to do a bone marrow transplant, find these boys and do a bone marrow transplant. Otherwise, they will not survive. So this just goes to show you the immune system. There's defects that affect our ability to fight infection. There's defects that affect our ability to prevent autoimmunity. And this is a balanced system and it goes both ways. So as I just said, there are many PIDDs that have extensive autoimmune or inflammatory complications, and we call these immune dysregulation disorders like APECED that I just talked about. Some of these diseases are very specific, like the APECED, which is the AIR gene. You mainly get a lot of endocrine organ attack, diabetes, thyroid, those kind of things, but you don't get a lot of other diseases. There's other diseases like one's called ALPS, which stands for autoimmune lymphoproliferative syndrome. Those patients just get autoimmune cytopenias. They get hemolytic anemia and they get ITP. So it's very confusing why these things do this, but it shows us we have multiple ways to regulate our immune system, and there's different defects. And this has really taught us a lot about how we regulate our immune system so it doesn't attack us. But most PIDD, primary immune deficiencies, have some risk of autoimmunity. And here's one I'll give you talk about. This is a very common one. I'm sure there's people on the call who may have this disorder. It's called common variable immunodeficiency. It's probably the most common serious immune deficiency. It's not always a single gene defect. As a matter of fact, about 2/3 of the time, we can't find a single gene. It's probably multiple genes. We're not sure about that, as I spend a lot of time thinking about. But in this disorder, you don't make normal antibodies, you don't make good poor vaccine responses, and you get a lot of bacterial infections, upper respiratory infections, pneumonias, those kind of things. What's interesting is that a vast majority of many, if not most of the patients with this disorder get autoimmunity. And one interesting observation is that we see that our patient CVID presents usually in the teenage years or young adult years. So they have a period where their immune system is working. What we often see is that they'll get ITP or hemolytic anemia, at 5, 6, 10 years of age, and then 10 years later, they get CVID. So something is off on the immune system in terms of like tolerance, and it's both ways. You can get infection, you get autoimmunity. So CVID isn't a good example of this. And this just goes to show you. So the top thing here, but pretty much everyone with CVID comes to attention because of infections. You get your antibodies tested and you have CVID. But these are all in the rates of complications of a bunch of stuff. So autoimmunity like ITP, hemolytic anemia, arthritis, about a third get this. I highlighted in yellow the autoimmune responses. I'm separating the chronic lung disease from infections, which is bronchiectasis, which is different than a granulomatous disease that we see quite a bit, that can attack the lungs also. They get GI involvement, they get liver involvement, and they also get higher rates of cancers and lymphoma. So you add these up, it's almost the majority of patients with CVID have some non-infectious complication. And this is actually the scary part, is those are the things that get these patients in trouble. If you look here, these are patients, this is the survival over 40 years of patients who just get infections. They get IVIG replacement, their infections get better. They have a pretty normal lifespan. They do pretty well. Not perfect, you can still get some things, but these are people who have autoimmunity or get lymphoma or get cancer. Their survival goes way down, or get lung disease. So all this other stuff that occurs is what really gets some of our patients in trouble. Okay, what about other autoimmune diseases? So it's a tricky question, because the common autoimmune diseases we talk about are like rheumatoid arthritis, multiple sclerosis, systemic lupus erythematosus. Some of these you need functional antibodies to get. So rheumatoid arthritis, the reason it's called rheumatoid arthritis, there's a thing called RF factors. These are antibodies. And if you can't make antibodies, then you're not going to be able to make rheumatoid factors. And that's part of the pathogenesis of rheumatoid arthritis. So patients with antibody deficiencies can't get rheumatoid arthritis, but interestingly, they can get arthritis. And it's confusing how this works, but it does happen. And we see this in a lot of antibody deficiencies. Similar with multiple sclerosis, similar issue. To a typical person with autoimmune deficiency who gets MS, you need good T and B cells for this to occur. And if you don't have good T, you're not going to get multiple sclerosis. But there are other types of brain inflammation, which we can see in other diseases. For example, in common variable immunodeficiency, some get brain inflammation, and there's a specific gene that causes that. So it's the traditional autoimmune diseases. Some they don't get, some they do, but these are not really common. And that's probably because you do need B and T cells to work for some of these disorders. And systemic lupus erythematosus is another one I'll refer to as lupus. And it's characterized by making antibodies to yourself, to your DNA, to your tissues. And it can be all kinds of manifestations of autoimmunity. So you think that if you don't have good T and B cells, you can't have it. So you can't have it with immune deficiencies. Well, actually you can, because your T and B cells work in some immune deficiencies, but then you can get lupus. So there's two cases of this, which is kind of interesting. One of which is a disease called chronic granulomatous disease. And it's a disease where your white blood cells can't kill. It's a disease that usually affects boys, but can affect girls. They can't kill certain bacteria, and it can be very serious. They get very sick. Usually we treat them with a bone marrow transplant. Interestingly, in the form that is X-linked that affect boys, moms who carry the variant can get lupus, and they get a specific type of lupus. So that's really fascinating. And the theory is that this disease, it's something called an oxidative burst. It's the way we make nasty chemicals that like bleach that help kill bacteria. It's also an important process to make sure our cells die normally and get out of our system. You don't want to have a lot of dead cells around, because your immune system will start seeing those and start causing problems. So a half of mom cells have the defect as well. Half of the cell, moms don't get sick because half of their cells are fine, but half of them don't have the ability to do this, and they probably don't die normally. And then our immune system starts seeing them, and then they start getting lupus features. It's kind of a fascinating observation. So, and then there's actually also, there's complement proteins, and these are proteins in our serum, and they work with antibodies to fight bacteria. If you're missing, there's 1, 2, 3, and 4. If you're missing these, you can get autoimmunity, and you usually get lupus. For example, C1q deficiency is like 90% get lupus. They also can get some bacterial infections, but they get lupus. So, and that's also because complement does a lot of other stuff. It helps get rid of dead cells and make sure our system isn't responding to maybe cells that died for other reasons. But these are incredibly rare disorders, and the vast majority of patients with lupus do not have one of these immune deficiencies. All right. So how do we treat these? Well, this is a little tricky and it worries us because you have someone with a poor immune system and then you're giving an immunosuppressant. Well, that makes us nervous, but you can in some instances, and we usually treat them how we treat other autoimmunity. So, for example, one drug that I love using is rituximab, and this is a drug that deletes B cells in your body. You infuse it. Some of you may have had this, and it kills all your B cells. Well, patients who have immune deficiencies are typically on immune globulin replacement. So depleting their B cells doesn't hurt them because they already have what B cells make. They get immune globulin and then they don't get sick. So this is a great drug, and we use this a lot, and we consider it quite safe in these patients. But there are other drugs we might use that we may use for arthritis and such. And we use those like you would in autoimmune diseases. We really watch them because we're nervous that we might suppress the immune system too much and then they might be getting other infections. So, but we generally treat them the same as we do with other autoimmunities. So, okay. I was trying to give kind of an oversight of autoimmunity and why you get it, but I can tell you that unlike what I think most people would think, autoimmunity is common in primary immune deficiencies. Some defects, genetic defects in autoimmune diseases, immune diseases only have autoimmunity and they don't get infections. Some give you just infections and some give you both. And this is actually very common. And basically the reason is that system of tolerance and that development of lymphocytes and killing self-reactive cells and all of that stuff is very complex. And if you start messing with it, you start messing with the thymus, for example, in DiGeorge syndrome. People may have heard of DiGeorge syndrome. They get autoimmunity. The thymus is not normal in those patients. So you mess with that system, and one of the effects is tolerance breaks down. So our patients get autoimmunity, and it's quite common. And the system is very complex and balanced. So that's why we watch it, and that's why we think it happens. Anyway, I hope this was enlightening. And I put my email down there. If you have any questions, I'm happy for you to write me. I was supposed to get my slides in weeks ago, but I'm a last minute guy. So I don't know if you had a chance to look at them, but you can certainly see the slides and think about them. If you want to contact me, that's fine. So thank you.
Thank you so much, Dr. Verbsky, for providing that interview. And I mentioned in the general chat here, please know that today's presentation, Dr. Verbsky's, will remain available on the CVent platform for people to go back and rewatch and try and take in some of the great information provided us, as all of our sessions are. So I encourage you, go back to some of the sessions maybe you haven't seen and you're gonna make a choice between, they'll be there for you, and so will this. So now we have some time available for Q&A. Before we begin, please remember that everyone's treatment and condition are unique. The information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. So we actually have quite a few great questions. I'm going to actually take myself off camera and start to read these to you, Dr. Verbsky. Are you ready?
Mm-hmm.
Okay. The first question we have is, what is the best way to confirm autoimmune disorders or not when one has all the signs but none of the positive blood tests?
So that's a very good question, because a lot of our blood tests we use for autoimmune diseases are antibodies. So for lupus, we do an ANA. For rheumatoid arthritis, we measure a rheumatoid factor. Patients with antibody deficiencies can't make rheumatoid factors and ANAs. They don't. So you can't use those tests. You need a good immunologist, rheumatologist, or two working together who understand this, because I have seen a lot of doctors make very false claims about patients who have immune deficiencies that just are not right. So you need someone who's familiar with immune deficiencies, and a rheumatologist doesn't just use lab tests. Lab tests only help us characterize things. What they have to look at is, do they have arthritis? So they will examine you. Is there arthritis? Now, some people just have joint pains and that's not arthritis. And that's why you need a rheumatologist to look at it. Other diseases, they have to look at what organs are attacked and what is the pattern, for example, and that's their job. But you do need a rheumatologist who's familiar with immune deficiency, specifically antibody deficiencies, because the test will not be positive. So you got to find the right people who kind of are familiar with this and know how to work it up.
Great, thank you for that. Our next question: is there an autoimmune disorder common in CVID patients that involves flares of muscle weakness combined with peripheral neuropathy and hand tremors? What autoimmune disorder might fit this, or what might make sense to investigate?
Well, like I said, in CVID, I've seen this. You can get brain inflammation, but it's not going to come and go. You're going to get, they get very sick. They may have seizures. They can have weakness. They have lots of stuff. And then eventually someone's going to do an MRI. You would do an MRI and say, is there something there? And that does occur. It's rare, but it occurs. So you would need to do MRIs and see a neurologist so they could see, is there inflammation in the brain causing this? And that can occur. It's pretty rare, but it can occur. So if somebody has weakness or a neuropathy and a CVID, I would definitely be seeing a neurologist and getting MRIs to be sure that's not happening, because that needs to be treated with immunosuppression, not IG replacement. So
thank you for that. How can lupus be diagnosed, confirmed in someone with CVID?
So I'm going to say you can't get lupus with CVID. So like I said, lupus is something that we don't see lupus and immune deficiencies, except for those two very specific examples I gave you. You can get other things like hemolytic anemia, ITP, arthritis. That's all part of lupus too, but you can just have those with CVID. So I would argue that it's not probably lupus, but you can have a lot of the features of lupus, and that's just CVID. And that's where a good rheumatologist can help you on this, can look at this and say, yeah, you have hemolytic anemia, you have arthritis. So you have features of lupus, but it's not lupus, it's something else. So.
Thank you. So you did touch on this a little bit earlier, but the question here is, how has our understanding of primary immunodeficiency disease and autoimmune disease, along with immune dysregulation, changed over time? Obviously, your perspective has changed. What has brought those changes to the forefront?
I think it's genetic. The amazing genetic advancements in 20 years, I've seen the number of immune deficiencies go from 50 to 500, and we're getting lots of defects in genes that regulate the immune system. There's a whole, I mentioned a couple, AIR, FOXP3, there's other ones, CTLA4, CD25. These are all immune deficiencies with autoimmune and immune dysregulation features, and it's taught us quite a bit about why we get autoimmunity. So it's been really fascinating, actually. We're getting a much better understanding as why tolerance breaks down and we attack ourselves. And most of that is with patients who unfortunately are born with a genetic defect where they have a strong component of autoimmunity. So it's unfortunate for the patients, but it's great for knowledge because it really has taught us a lot. So
thank you. So another question here is, in NK cell deficiencies, do you seem to find a lot of eye and skin inflammation in those with NK cell deficiencies?
Well, autoimmunity, as I mentioned, is really T cells and B cells. NK cells are lymphocytes, but we consider those innate. So they're not cells that learn and get smarter as they get activated. And that's important. Like, for example, immunologic memory. So when we're kids, we get vaccinated. And what that does is teach that T and B cell to be a better T and B cell. NK cells don't really do that. So they don't really play a huge role in autoimmunity. There may be some roles, but it depends on, they do control certain viruses like herpes viruses. So if you're having like herpes virus outbreak, that could cause skin inflammation, can cause all kinds of stuff. So but I can't say there's something about NK cells and controlling inflammation, at least not that I'm aware of. There might be some things, but it's not a real common thing.
Thank you. Next question. How is it we can have autoantibodies that don't show in tests while we're on IG therapy?
Well, so when you're on, well, if you're on IG therapy, you should not make autoantibodies because you shouldn't make antibodies. So, so they will be negative. Now, there are autoantibodies in IVIG. Our antibodies react with ourselves commonly. It's just not bad enough to cause disease or not high enough titer. So you could have some like an ANA, for example, for lupus. You can see that in IG replacement. It's because ANAs are common in people and they're not, we see them in lupus, but healthy people can have them. So these autoantibodies are a little tricky because healthy people can be positive for things and not get disease. And it's complex, and I'm not even sure I understand that. But there are some in IG replacement, like ANAs are positive. I'm sure you could get a rheumatoid factor low level in IG. That's why we don't rely on those tests. Rheumatologists, you have to look at skin and joints and organs and put the whole thing together. It's not just a lab test and you have a disease. Particularly when you can't make antibodies, we shouldn't be using them anyway. So
interesting. Thank you. Our next question, is there an autoimmune disease that can cause a low functional C1 esterase inhibitor?
Yes, there are antibodies against C1s. I think you're talking about hereditary angioedema, which is a C1 inhibitor, and that's you get swelling and abdominal pain. There are, I believe, that's kind of more on the allergy side of thing. I don't deal a lot with C1 esterase. That goes to our allergist, and I'm a rheumatologist. But you can make autoantibodies to C1 inhibitor and delete it and get it out of your system and get features of what's called hereditary angioedema. So that does happen. You can make antibodies to anything and get disease from it. So
interesting. Are there guidelines in place prior to prescribing medications such as rituximab to prevent secondary immune deficiency?
No. So we use rituximab in people with autoimmune deficiencies all the time for lupus, arthritis, and what have you. And I see a lot of people, it's not infrequent, it's not common, but we do see people who got courses of rituximab and then became very low. They never recovered. Your B cells will recover after rituximab. It takes about 6 months. But sometimes they don't recover, and then you become hypogam, and we call that secondary hypogammaglobulinemia due to Rituxan. We give it to patients who are on IG replacement because we don't have to worry about that because they're on IG replacement. But it can happen the other way, and then they get put on IG replacement. So there's no way to know why that would happen. And a lot of people get rituximab. They might get 1 or 2 courses, come off it, and they don't ever get sick with it, and it all recovers and it's fine. So it's a complicated question.
So there are actually a few questions around the use of rituximab and that. So if a patient is on rituximab and on immune globulin replacement therapy, how do you time or space out, or do you, the different infusion types of immune globulin or the rituximab?
Well, rituximab is a standard schedule. It's every 6 months. It's a couple doses every 6 months. IG replacement is either you do it weekly or you do it monthly. So they're given independently. So our patients who have CVID who get rituximab, we give a lot of them rituximab. They just stay on their IG replacement, and we just give rituximab when we need to. So there's no interaction between the two. So.
All right, thank you. There are quite a few questions here. I'm trying to combine them on the go as I'm listening to your great answers. Let's see, are there any forms of cancer related to autoimmune disorders?
Yes. There's higher rates of lots of cancers in autoimmunity. So for example, when you have autoimmunity, your T and your B cells are working too much, right? Because they're constantly active. The same thing goes when you have an immune deficiency like CVID. We also see that the B cells, and they get overactive and then stop working. Lymphoma is common in both. Well, not common. It's more common in immune deficiencies. Like I said, about 8% of patients with CVID can get lymphoma. They also get gastric cancers and other stuff. But we also see higher rates in autoimmune diseases like rheumatoid arthritis. They can get lymphoma. And that's probably a similar mechanism as the cells are too active. And when things keep dividing and they're active, you start getting genetic variants, and then that leads to cancer. So.
Thank you. We've got a question here from an individual states that they've been getting a lot of thrush as well as periodontal disease in addition to their primary deficiency disease. Should they see an endocrinologist?
That's a tough one. That APECED disease is incredibly rare. So, and I don't know who posted this, but if they have an immune deficiency, I'm not sure what immune deficiency it is. There's a lot that give you thrush and problems, or other reasons to get thrush, like, well, thrush and gingival mouth disease happens with neutrophil problems. So if they have a neutrophil problem, that explains it. Thrush can also be from steroids. If people are giving you steroids, sometimes people have diabetes and they can get thrush. So there's other reasons, but if your immunologist should consider it, if you have very bad thrush, as could you have this disease? And then they would want to check stuff like your parathyroid and adrenal gland. But that disorder is incredibly rare. It's the vast majority of people who have thrush won't have that disorder. It's just an example of what it teaches us about the immune system. So,
thank you. Another question here: is fibromyalgia connected to autoimmunity and primary immunodeficiency?
Fibromyalgia is a very tough one because we see it in rheumatology quite a bit. It's more of a neurologic condition, but it's hard because we don't have like good markers for it. For some reason, we don't understand this. People get very sensitive to pressure. You can touch them in certain areas and excruciatingly painful. It's really more neurologic. So we see neurologic involvement with primary immune deficiencies, but I wouldn't say it's fibromyalgia. I'd say it's probably different, but it's also a very tough disease because we don't have like a marker. We can do a test and say, yes, you have this, or no, you don't. It's something that rheumatologists, they kind of get used to seeing. Yep, we've ruled out all the other stuff. It sounds like this is fibromyalgia, and you actually treat it with neurologic medications. You've seen Lyrica and pregabalin and these things. They're actually targeting your nerves, which for some reason are overly sensitive to pain.
All right. Another question from our audience. In those with co-occurring autoimmune or autoinflammatory conditions, is there a higher rate for severe adverse reactions with IVIG?
That's an interesting question. I don't think so. So, well, there is one example, which is we're taught this all the time, and it's probably not that significant. But if you're really like truly IgA deficient, and you get IVIG, there's a little IgA in it, and you can react to it. But that's usually people with normal immune systems. So patients with CVID can't make IgE, for example. So then you can't have anaphylaxis to something. It's hard to know why we get infusion-related reactions with immune globulin. It's a protein. It's a lot of protein. The thought is it clumps together and deposits places and gives you several days of headaches and other issues. But I can't think of any immune disease that would, or immune deficiency or inflammatory disorder that would make the reactions worse. I mean, I guess if your vessels were inflamed, these proteins you're infusing may deposit in certain areas. So I can hand wave and tell you, sure, that makes a little bit of sense, but I can't think of anything specific where I'd say, oh, that's why you're getting bad reactions. It happens in people. We don't really understand why some have bad reactions and some don't. So,
all right. So we have a question here. Individual had an enlarged spleen with ITP and had it removed. Their platelet levels returned to normal. Are they still at risk for ITP coming back?
That's a good question. Because many of our patients have ITP, and splenomegaly is also common. And when your spleen's big, your platelets can kind of end up in the spleen. So you can actually have both. So if they took your spleen out, which we don't like taking spleens out, but if they took it out and it fixed everything, I'd say that it was probably just your spleen was big. But then the question is, why was your spleen big? the spleen's big in CVID just because of the disease. So I guess the question is, was it taken out because you have CVID and splenomegaly? I'd say, yeah, you still have a risk of ITP. But if it fixed it and your levels are perfect, I'd say it's probably not going to happen. It's kind of hard to say in this instance. I'd have to know more details about why the spleen is big. So
Understood. Here's an interesting question. They're all interesting though. Is there a reason an autoimmune flare always occurs post-infection or vaccination in primary immunodeficient patients?
yeah, there's probably a very good reason, which is, remember I was showing you that when you have let's say you have a self-reactive T cell and it's out in your tissues, or a B cell or whatever. And these cells are always seeing your self tissues, but they're seeing your self tissues in a very quiet environment. So we're not always having inflammation. They're just floating around, seeing the antigen, but they're not getting activated properly. And that's exactly what illness, viral infections, and vaccines are doing, is they're trying to, well, viruses, it just happens, our body senses it. But vaccines, the idea is you've got to cause some inflammation to get those T cells to go. So it makes perfect sense. So we see, for example, in kids, it's not unusual to see a viral infection, and then you might get arthritis for a couple of days or a week or two, and then it kind of goes away. We don't call that an autoimmune disease, but it does make sense because what you're doing is stimulating another part of the immune system, which can then stimulate the T cells. So this part of tolerance is that seeing antigens without inflammation, the T cells don't go. But seeing antigen with inflammation, they go. And what you're doing with a virus or a vaccine is causing inflammation. So that actually makes perfect sense.
Got it. It does make sense. Question here from a relatively young individual of 32 years old and just recently diagnosed with CVID. So very early in their journey in our community. And their question is, how often should one proactively see a rheumatologist throughout their healthcare journey?
If you're followed with the immunologist, they should be asking questions. Autoimmune diseases have symptoms. So you're going to have joint pain and swelling and stiffness for weeks and weeks. You're going to have severe fatigue. And then they should be thinking about, like, well, has your thyroid been attacked? And now you have hypothyroidism. If someone is fatigued and cold all the time. If you have a weird rash, they may send you a dermatologist or rheumatologist. So we don't usually I'm a rheumatologist, so my patients kind of get that benefit. But I mean, you can ask your immunologist, if I have some symptoms, could I see a rheumatologist? It's probably fine to see them once, but I don't think, yes, these are common, but we usually don't do anything until you have symptoms. So the point is that if you have symptoms that are persisting, tell your immunologist, man, I've had a swollen knee and it hurts for 3 weeks. Tell them, and he'll say, or she will say, let's get you to see rheumatology, or that looks like arthritis. Let me check on it. So, but you don't need to be screened frequently. We don't do that. It's really based on symptoms. So.
Okay, I think we have time for one last question here before we have to wrap up. So I apologize in advance to everyone if I didn't get to your question specifically. We've tried to present a variety of questions here, group some similar ones together. For last question, and a few people ask around this a little bit, having eye issues, and particularly eye issues that might be tied to thyroid. So one of the questions is it possible to have thyroid eye issues if the thyroid blood tests are normal? This individual just happens to have CVID.
Well, there is a type of thyroid disease, Graves' disease, where the antibodies that you make against the thyroid for some reason react with the muscles in the eye, and the eye pops out. So I don't know what you mean by eye issues. There are other things. CVID, it's common to have conjunctivitis, and that's probably because of, even though you're getting IgG replacement, remember IG replacement is just IgG, IgA is what goes to the eyes and helps fight infections and stuff. So, and then there's also inflammation inside the eye. So it's a hard question without knowing more details of what they're asking. In Graves' disease, you get eye involvement. You get what's called proptosis. It pops out, and you get a very active thyroid. So you're very hyper and you lose weight. And then as the thyroid dies, you become hypothyroid and you're cold and you're tired and those kind of things. So, I'd have to know more about it to ask specifically what's happening here. But if you have CVID, there's other reasons to have eye involvement. It doesn't necessarily have to do anything with the thyroid. So
Great, thank you for that. Well, with that last question, our time together has come to an end. Thank you so very much, Dr. Verbsky. It's been an honor to have you join us today. This session is just one of 39 unique learning opportunities provided through IDF's 2023 PI conference. We hope you continue tuning in today as we explore other critical topics for the PI community. And once again, I'd like to thank our partner Takeda for supporting this learning opportunity. Enjoy the rest of the conference, everyone. Have a great day. Thank you.